This conference will now be recorded.
Thank you for participating in Complementary Integrative Rehab Medicine Networking Group webinar series, especially during this headache time. My name is Pei-Shan Wen. I am assistant professor at the OT department at Georgia State University. And I'm co-chairing this webinar series with Matt. Matt, would you want to introduce yourself?
Yes, hello everyone. Thank you for tuning in to our webinar series. My name is Matt Erb and I'm a physiotherapist located in Tucson, Arizona. And I'm co-chair with Pei-Shan for this Complementary and Integrative Rehab Network webinar series. I just want to mention our upcoming virtual conference, which we'll just put a slide up for those that aren't familiar. Coming up in October, was originally in Atlanta, but will be held virtually. And also want to mention a few housekeeping items for us today. Please always keep yourself muted, your phone or computer. You can use the chat feature to submit any questions that may come up for you during the course of the presentation. And we'll spend a little bit of time answering any questions that are presented. You have any Wi-Fi interruption, just dial back in and join the meeting after the fact. You can come right back on. And this meeting is being recorded. You may have seen that. So again, just keep yourself muted during the presentation. So I'll turn it back over to Pei-Shan.
Yes, so today we are very excited to have Dr. Ginsberg. Dr. Ginsberg retired as a clinical psychologist, neuropsychologist from the Columbia, South Carolina VA Hospital in 2019. During his active career, Dr. Ginsberg held a basic science research assistant professor in the Department of Pharmacology, Physiology, and Neuroscience at the USC School of Medicine, and adjunct professor in the Department of Exercise Science at the USC Arnold School of Public Health. He is an advocate for integrative management of chronic pain and PTSD using autonomic self-regulation, a self-empowerment mind-body treatment. He has authored and co-authored more than 40 peer-reviewed scientific publications and served as a scientific reviewer of research grant proposal to NIH, VA, and DoD. He has aided and reviewed numerous publications and published, and he's a PI and co-I on research grant funded by DoD, NIH, and VA. He has given many invited presentations on this related topic, HRV and HRVB at scientific meetings, academic seminars, and cyber seminars. Welcome, Dr. Ginsberg.
Thank you for that introduction, Pei-Shan, Matt, and I thank you and all of the good folks at ACRM who have invited me to present this webinar. This is something I enjoy doing very much, and I feel very passionate about the use of autonomic self-regulation in amelioration of chronic illness. The topic of this webinar today is applications in chronic pain management. Sensitized chronic pain causes stress responding that is moderated by effects of heart rate variability biofeedback on the baroreceptor reflex. And I'm going to be zeroing in on this term here, heart rate variability biofeedback. I will use the term autonomic self-regulation at times and explain how the two are interrelated. That's just a little brief contact information about me. A few disclaimers and disclosures I want to run over quickly. I am a neuropsychologist by training. I'm not an expert in cardiology, physiology, medication, headache, or pain. This is just a natural extension of my interest in cognitive psychophysiology. I have no conflicts. The slides are original or acknowledged or available. If you use them, please acknowledge. Some of these portions have been presented in previous webinars that I've given. They are not intended to replace, substitute for formal education. The models are didactic and heuristic. They are referenced and consistent, but they also are going to have incompleteness, and there may be things that could be discussed and corrected or revised, expanded, and so on. Just a few more quick disclaimers. There's no commercial product, process, or opinion here, and no reflection of any institution or organization. If you are a clinician, you would be responsible for applying or employing any of the interventions that are indicated in this. So this is not a substitute for professional training or accreditation. So here's the basic model that I want to bring to you today. As you can see in the center there, something happens. There's some event, whether it's stress or allostasis. From some event, two pathways are possible. One is the disease pathway. The other is a health pathway that can be assisted by heart rate variability, biofeedback, or autonomic self-regulation. And this is the basis for the self-empowerment, because this biofeedback technique is something once learned can be applied by the individual patient, and therefore giving you the option to choose which pathway you go down. So in a nutshell, this presentation will attempt to provide for you, and it is fairly ambitious, as I tend to be. The slides will be available online for a little more study, but basically the points will be that chronic pain is sensitized by chronic stress. ASR is a combination of heart rate variability biofeedback using resonance frequency breathing in combination with positive emotional state and mindful attention. Oh, I see a typo there, which serves to increase the baroreceptor reflex. The effect of the increased baroreceptor responding is to amplify heart rate variability around the 0.1 hertz peak of the power HRV spectrum. The distinct 0.1 hertz peak is characteristic of what is called coherence, and coherence is associated with improved stress resilience, emotional self-regulation, and therefore a decrease in the sensitized chronic pain. So the model can be simplified or presented like this. Chronic pain plus stress leads to sensitized chronic pain, which increases inflammation and decreases heart rate variability. Sensitized chronic pain with increased inflammation and decreased heart rate variability, which has autonomic self-regulation applied to it, will increase heart rate variability, will increase parasympathetic nervous system activity, will increase baroreceptor responding, which will decrease the stress response, decrease inflammation, and thereby decrease the adverse effects of sensitized chronic pain. So what is sensitized chronic pain? We start with kind of an overview here, and we have two basic causes, fundamental causes, nociceptive and neuropathic pain, and then an area of mixed, which includes certain types of pain conditions. It is mea culpa, and I saw this today. Migraine should be on this list. When I redo this, migraine will go somewhere right in here. I will have more to say about migraine in a couple of slides, but migraine I think is best fit under nociceptive, possibly migraine, but we'll talk more about that. So neuropathic pain is bidirectionally activated by the sympathetic nervous system. And so most of what I'm going to discuss autonomically is a better fit, you might say, or is going to be more effective for nociceptive type of pain conditions. So this is a overview. I hope my slides are being fully displayed here. I have a frame on my screen, which is indicating that the bottom line may be cut off. I hope not. But anyway, a simple model here of nociceptive pain starts here with an external stimulus. It is transmitted to spinal column where it is received, transmitted to the spinal cord from the anterior horn, sent up to central nervous system where it is processed. Descending pain modulation fibers return to the spinal column, which are intended to damp down the pain signals. And at the synaptic level here, glutamate becomes activated in the transmission from central nervous system, from the anterior to the spinal column before transmission to the central nervous system. And this is the basis for some of the more common pain relieving medications. So if we have an acute nociceptive condition, that is, simply speaking, hit your thumb with a hammer, you get the stress response in addition to the pain response. The pain is transmitted from periphery to central nervous system where it's processed, going up to cortex, and you have a pain and a stress response acutely, and descending pain fibers will then modulate the pain as much as can happen, and tissue repair begins, and the pain will end. And when the pain ends, the stress ends. So activation of the stress response then goes through two major pathways, the sympathetic sympathomedullary pathway and the hypothalamic pituitary adrenal, or the HPA system. They do have some overlaps, but they're two distinct stress response systems. This has some bearing on the application of the autonomic self-regulation. As you can see, the longer term, or this would be more of the chronic stress type of reaction, is through the HPA, and the SAM is the more immediately responsive, you might say, emergency response system for stress response. So when we have the stress response system through the HPA become activated, we have a wide variety of neuromodulators that are released and become active. And this model here is very well known and is thoroughly studied through both translational as well as human models in neuroscience. And it is the negative feedback system, which will shut off the stress response, which is stimulated from the adrenal gland, the adrenal cortex, after the stress has been perceived. So when stress ends, there's a shutoff of the active stress modulators. Now let's imagine that the nociceptive, or the pain stimulus, does not end, and we now have a chronic pain condition. We are then going to have a chronic stress response system accompanying that chronic pain, which leads to a degradation of the descending pain modulation system. Well, when that happens, we get into an autonomic state that has been called the immune runaway train. If the pain does not end and the stress does not end, we have a situation of a status of HPA overdrive. We lose the glucocorticoid inhibition of the pro-inflammatory cytokines that accompany the stress response, the proliferation as well of peripheral inflammation. This tends to heighten the sensation of pain irrespective of the external pain stimulus. We get disinhibition then of the descending cortical pain modulation, depletion of the catecholamines that are necessary to reduce the pain, and in addition, we have a depressed behavior and mood. This is, you might say, a picture of the chronic stress or sensitized pain that results from chronic pain. So using another depiction of this, the acute pain does include enteric nervous system or food. Diet is a function here. I'm not going to go to any length in this, but turns out that diet is very relevant for the development as well as the amelioration of sensitized pain, central sensitized pain, which is accompanied now not only by peripheral inflammation, but by neurogenic inflammation. And you can see here I'm having to skip over steps to fit this in, but these things are documented and there are references for them. So when we have in the central case the pain injury, which is exacerbated by diet in a broad sense, leading to both peripheral and neurogenic inflammation, sensitization. Now we have a spin-off cycle here leading to a sick role, as well as changes in mood and emotion, cognition, can result in substance abuse as an inadequate pain treatment, disability leading to kinesiophobia or fear of movement due to fear of pain, decreased motivation, sleep disorders, pathology, and so now we have a cycle around a cycle. Very serious, very problematic situation. Well, when we get into this case, it turns out that humans tend to be depressed. It causes depression. That stress can express itself as depression in humans. Animals, of course, don't report a depressed mood, but are very similar in their physiological profile to chronic stress. So a chronically stressed animal looks a lot like a depressed human in terms of their modulator and their autonomic status. Well, central sensitization is associated with a number of common pain conditions: abdominal fatigue, pelvic, low back, nonspecific migraine. And here we'll take a minute just to unfold that a little bit. Migraine is episodic or chronic, resulting from peripheral and neurogenic inflammation that causes nociceptive pain and central sensitization. It is believed to be caused, and migraine is still poorly understood, I would say. Now, I'm not an expert in the field, but it's hard to find a definitive, clarified picture of migraine. It is believed to be caused by vasodilation in cranial blood vessels. Tension headaches, conversely, thought to be caused by vasoconstriction. During a migraine, and I hope you can see this bottom line, neurogenic inflammation will exacerbate the pain. So inflammation is a major part of this picture. Well, what is autonomic self-regulation? Rescue from SNS hyperarousal, you might call that HPA overdrive, due to stress from chronic pain. So we can approach, you might say, or we can enter the HPA overdrive and the SNS hyperarousal through autonomic regulation, through conscious control of heart rate. So autonomic regulation then does involve heart rate variability with positive emotional state and mindfulness. In coaching it, we use the paced breathing at resonance frequency, which produces coherence. I'll talk more about coherence in a little while. We apply mindfulness or imagery and positive emotional state. Now, all of these serve to be their own entry point. Mindfulness is used as an approach or a treatment, an integrative treatment for many types of chronic and behavioral disorders. Positive emotional state, similarly, occupying the mind with thoughts of compassion and gratitude and so on. These are all, I think, different pathways to the same endpoint, which would be mindful attention, resonance frequency breathing, positive emotional state, converging on heart rate variability, and leading to this thing called coherence. So let's take a minute to talk about heart rate variability, baroreceptors, resonance frequency breathing, and coherence. Heart rate variability, for those of you who don't already know, is simply a regular change in the interbeat interval, which is measured in milliseconds. Just remember that a healthy heart is not a metronome. It does not have a single beat to beat time difference. So we can illustrate this by looking at an heart rate, two types of traces or recordings of heart rate at 60 beats per minute. We could have beats that are equally spaced at 1 second, or beats that are spaced in some pattern, 0.9, increasing to 1.0, increasing to 1.1, then decreasing to 1.0, 0.9, and back up to 1.1. So this sort of begins to form this idea of a curve or a pattern of a sine wave with increasing and decreasing IBIs or pulses. So this is regulated in large part by the autonomic nervous system. The parasympathetic system branch of the autonomic nervous system is responsible for the slowing portion, and the sympathetic nervous system here through the ganglia is responsible for the acceleration portion. And so we have this interplay then between cardiac acceleration and deceleration, occurs on a very rapid scale, on a scale of seconds. So breathing will strongly affect the function of the sympathetic and parasympathetic nervous system in their interplay. This is a depiction of that as we draw in air, we expand the chamber, and as we push down, you might say, or exhale the air, force the air out, the volume decreases. This then can be thought of as the lung capacity. When we draw in air, there's expansion here, negative pressure. And then when we contract and exhale, we push the air out. So this is pushing the air out. This is drawing the air in, leading to the expansion and increase. And this is a metaphor for the lungs, where when we exhale, we push up on the diaphragm, push air out. Whereas when we inhale, the diaphragm descends, draws air in, and there's expansion here. Well, this also affects the pressure in the thoracic cavity. And it's this pressure increase which is important for regulating the blood flow. So if we go through a respiration cycle, when we inhale, we expand, we draw in, and that will increase heart rate to try to compensate then for the increased amount of volume. And as we exhale, then the thoracic volume will decrease, the pressure inside will decrease, and that the pressure will increase inside the cavity. That will cause a decrease in blood flow, which shows itself as a change in heart rate. And so then we start the cycle again. So as we inhale, volume, blood pressure, and heart rate will all increase. And as we exhale, the volume, blood pressure, blood flow, and heart rate will all decrease. This is regulated through central nervous system. The sensors are the carotid and the aortic baroreceptors, which sense these changes in blood flow and pressure in the vessels. It all goes through a central nervous system here, including cortex, which is monitoring these baroreceptors and causing outflow through the parasympathetic vagus nerve, as well as through the sympathetic cardiac nerve, to create this interplay in heart rate. So we can try to depict this then with the neural circuits at central nervous system level. It involves the paraventricular nucleus sending signals down via the nucleus tractus of the solitaris, which then affects ultimately as output acceleration as well as deceleration, as we have these baroreceptors sending signals that are responsive to changes in blood flow. Well, there's a timing factor here. It's very important. The processing of signals as heart rate and increase in blood pressure in the vessels are processed through central nervous system. There is a time delay. There's a time delay in sending the signal back to the output, which is heart rate ultimately via the sympathetic ganglia or the vagus, depending on what the signal is in the origin. And it's this time delay here which is the basis for the coherence, or the 0.1 hertz. Well, let's take a look at that. As we affect our respiration, as we slow our breathing, we're affecting heart rate, which in turn is affecting blood pressure, which is sensed by baroreceptors, processed by brain, sends signals back to heart rate. There is a second loop here involving vascular tone, which is operating at a similar frequency, 5 seconds and 15 seconds, which will allow then for some phase locking of heart rate changes and baroreceptor function with vascular tone. So this is an animation of that. It's intended to describe the putative model of this coherence, which is a result of the baroreceptor. So you can see once we get going here that the change in vasomotor tone is quite a bit slower. So as the chest cavity, as we're breathing, we are also affecting the size of the capillaries through constriction and dilation, also through the autonomic nervous system. So there is a cycle here in which the two can be said to be phase locked. So what happens then when we reach this coherence at about 6 breaths per minute? We get the overlap, we get the maximal overlap of baroreceptors with heart rate, and that then produces this more or less whopping change in min to max over the respiration cycle, a whopping change in heart rate. And this typically is around, one cycle typically is around 10 seconds which is 6 per minute, which corresponds to 0.1 hertz, which produces the maximum change or difference from low to high over a respiratory cycle. And that is the notion of max HRV and coherence. So heart rate variability is related to the frequency of breathing at about 6 breaths per minute, which corresponds to the 0.1 hertz. Respiration and heart rate variability will synchronize, producing resonance, which is the indicator of coherence, which is modulated through the baroreceptor resonance of heart rate variability. Resonance is the tendency of a system to oscillate with an amplitude at some greater amplitude at some frequencies than others. Relative maximum is the system's resonance frequency. Small periodic driving forces, normal heart rate variability at normal respiration becomes enlarged. So you can think of that as pushing the person in a swing. You can give them a larger amplitude of their cycle if you grab the swing at the height and give it a push down. So resonance of HRV due to baroreceptor at resonance frequency breathing leads to 180 out of phase with HR oscillations. Therefore, heart rate oscillations are amplified at resonance frequency. Maximal blood pressure is reached after a 5-second delay from the previous cycle of the baroreceptor mediated blood pressure increase, which therefore occurs at the same time that heart rate reaches a minimum, which lowers heart rate even further. Conversely, minimal blood pressure occurs as heart rate reaches its maximum and will increase the heart rate even more. Approximate 5-second time delay in baroreceptor responding reduces arterial pressure oscillation resonance with heart rate variability. So this is a quick animation of that at the right breathing frequency. Your heart rate is naturally varying. Baroreceptor, the blood pressure is out of phase with that, leading to a baroreceptor response that is in sync with heart rate and maximizes heart rate at the same point that blood pressure reaches a minimum. So heart rate variability coherence is a physiological state that is produced when resonance occurs in the feedback systems, controlling heart rate, arterial blood pressure through the baroreflex, and vasomotor tone, and is associated with improved adaptive behavior. Coherent heart rhythm is defined as a relatively harmonic, sine wave-like signal with a relatively narrow, high amplitude peak in the LF region. And I have not had time to explain the different regions of the power spectrum of heart rate variability, but 0.1 hertz is in the low frequency region of the heart rate variability power spectrum without major peaks in either VLF or HF. So it looks something like this. The breathing frequency at around 6 breaths per minute, you get a maximum in your power spectrum, which corresponds to amplified heart rate variability or maximum difference between the lowest and the highest IBI within a respiratory cycle. It also looks like this. This is just another depiction of it. If we take a 10-second cycle where we're breathing 5 seconds in, 5 seconds out, heart rate variability will become synchronized with that, whereas the blood pressure is out of phase. So the properties of coherence are all generally pretty good. Resonance frequency includes sharp peak here associated with alertness, responsive, self-regulation, cognitive function. It's not the same as relaxation. We call it, it's actually an aroused or an alert. It's an alert state. So during normal respiration periods, it is not typical to exhibit coherence. So again, in short here, the model is chronic pain plus stress leads to sensitized chronic pain, increases inflammation, decreases heart rate variability. If we add to that autonomic self-regulation, we get an increase in heart rate variability, increased parasympathetic branch, increased baroreceptor responsivity, a decreased stress response with lowered inflammation and a decrease in the sensitized chronic pain symptoms. All right. That is I think I'd like to check in now and find out if we have questions or if there are parts of the presentation that we can look at a little more in a little more depth. So let's see. Do I have one of my leaders here? Again, do we have questions? Yes. Do we have questions?
Yes, we have a question coming in. This is outstanding. Thank you. For someone who does not have HRV feedback equipment, how do you suggest applying the principle in the clinic for persons experience persistent pain?
Well, that's a wonderful question. I would be willing to say that the best way to achieve the autonomic self-regulation is with a coach and using some equipment. The equipment does not have to be sophisticated or expensive. A coach is very helpful in guiding you to acquire the skills. So we say that heart rate variability biofeedback as a part of autonomic self-regulation is an acquired skill. Once you have the skill, then it's a matter of practicing it. And we use the biofeedback approach in order to bring into conscious awareness those physiological changes that are accompanying slow breathing, resonance frequency breathing, and positive emotional state, and attentional focusing, so that you can consciously be aware of when you have achieved some coherence. So it is helpful to have the equipment, to see it, to visualize it. Now, I certainly could have presented a lot of information about the biofeedback technique that includes the attention focusing and includes the positive emotional state induction, as well as a discussion of some of the equipment that's available to assist the patient or the individual in acquiring the skill. But the important point is that once you've acquired the skill, you're not dependent upon the coach or the equipment. Once you understand and can sense and consciously become aware of being in coherence, you can practice it at your desk, on the bus, anytime during the day that you have just a couple of minutes to go through a few breathing cycles. So while it's important and probably efficient to have the coach and the equipment to acquire the skill, it's really not necessary. And some people can learn resonance frequency breathing and the other aspects of attentional focusing and emotional state. You can acquire that through yoga or even just through self-teaching, just sort of figuring it out yourself, and many people do. So in the clinic, we find even some of the clinical patients with pain and PTSD, who are the two populations I've worked with, we find that some do come in with a fair amount of ability to produce coherence on demand. So it is possible. For many people, however, who have sympathetic overdrive and HPA, hyperarousal, that's what they need, and that's why they're sort of quote unquote in trouble, is because they have not learned or figured out on their own how to put themselves and create the state of coherence. So to answer the question specifically, you can, if you just practice breathing as is trained through breath control, through meditation, through yoga, perhaps no more complicated than a stopwatch and timing your breath cycles. My concern would be, though, that if you just try to slow your breath without some visual feedback and without some coaching, that actually can be anxiety producing. That can create a sense of hyponatremia, or shortness of breath. It can actually, you can become breathy and actually get worse. You can faint from just slow breathing if you're not under some type of monitoring or supervision. So while the endpoint is very important, it's very potent, really. It's simple to achieve, and it kind of boils down to just breathing at resonance frequency breathing. The resonance frequency, however, does vary slightly from individual to individual, although it's within a fairly narrow range between about 5 and about 7 breath cycles per about 5 and 7 breath cycles per minute, which is a range of maybe 8 to 14 seconds per breath cycle. Don't confuse that with respiration rate. The breath cycle and the respiration rate are completely different. So if you have a respiration rate of 12 per minute, then your breath cycle is much faster than that. So each breath is shorter. So to get to 6 breaths per minute, you have to get to a respiration rate of 6 breaths per minute, you have a single breath cycle of about 10 seconds. So to get to that rate with supervision and with some visual feedback, really encourages and enables, facilitates acquisition of the skill of coherence, which can then be practiced on your own. Now, just a quick word about the equipment. These days, in the last, I would say, even 2 years, the amount of equipment that's available for producing feedback of some sort, whether it's tactile feedback like a pulse counter, or through a computer screen which gives you visual feedback, or a timer that will report. I mean, that has increased enormously. And things like Fitbit, it's that simple in a way to track. But just tracking your heart rate is not the same as monitoring your heart rate variability. So there's a mid-range of equipment, of devices, which is essential to really understanding and experiencing the breath cycle or the autonomic self-regulation when it's occurring. So the simplest case is a computer setup, a laptop computer system with a disk, software program, and a sensor. The sensor can be very simple, such as a fingertip photoplethysmograph, which is abbreviated as PPG, fingertip sensor, or an earlobe sensor that will pick up the pulse. It will compute from that pulse, it will compute the power spectrum density. That is, it will count the beats per minute or the beats per second. It'll record the individual beats, the individual IBIs, and convert that. And regrettably, I didn't really present the how you go from pulses to frequencies, but that equipment can be fairly simple. It requires some fairly medium sophisticated software programming to calculate the frequencies, and therefore to understand what frequency range your heart rate is. And that can be done for just a couple of $100 at a minimum. A couple of $100 is enough to buy a good quality software program to load onto a laptop system with a PPG sensor for either fingertip or earlobe, which produces dazzling screen displays of heart rate and animations, and is very, very helpful. So I would say that if you have a laptop system with a PPG sensor or some type of visual feedback, and the fingertip sensors are also quite advanced now, you can learn, you can self-learn. So if anything, the software program and simple sensor is more important, perhaps, for a motivated individual than is the coach. But if you're coming from a situation of some type of behavioral health disorder or chronic PTSD or pain, for example, a cancer survivor recovery, it really helps to have a coach who can pad and fill in some of the corners with some good old-fashioned counseling and help you achieve that state of alert awareness that we call coherence. So I'm going to stop there. Hopefully that's sufficient answer to that question. Pei-Shan, you have any feedback for me?
That's great answer. Thank you. And we have another question. We only have 3 minutes left, but this question is how you address the challenge of how to best convey that positive emotion experience can carry beneficial impact on the top of resonant breathing, but
No, yeah, go ahead.
But also acknowledge that often persons experiencing persistent pain struggle with difficult emotions as a result of pain. We don't want to suggest think or feel positively and then that will fix your pain. I have sometimes struggled with how to support pro-social and positive emotional experiencing within the lived experience of persistent pain.
Right.
Yeah. So
Is there more? Is there more to the question?
No, but does this make sense? Like, and not.
Yeah, I understand the question.
Yeah.
And that's a wonderful question too. And that is not a simple answer either. It's almost anthropological. And I'll try to just cut to the chase and give you an answer there. You know, in small scale societies, the shaman depends upon belief in the treatment. And those treatments are unreliable. So if you don't have the belief in the shaman, then you are not going to respond to whatever his intervention is, which may not be reliable in the first place. But belief is an important part of these type of interventions. Now, if we fast forward to something like psychotherapy, does that depend upon a belief in the power of the healer? Do you have to believe that you're going to get better if you do what the healer says? If we go even further to medical treatments or medication, do we believe that if we take the right medication that it will help control our high blood pressure or reduce the size of a cancer tumor? And the answer there typically is yes. We've relied on scientific validation for these treatments, which enhance the belief or the willingness of the patient to follow the directions of the provider. However, if you're a cancer patient or have blood pressure and you have no belief in the medical system and you take the medication, you will nonetheless get a benefit from it. So it does not depend upon belief in the provider. Well, psychotherapy and heart rate variability is somewhere in between that. We don't have the strong validation. We have this belief, and we have a lot of evidence that if you do what the provider says through counseling and through heart rate variability or autonomic self-regulation, it will produce a benefit. In my opinion, the application of heart rate variability, autonomic self-regulation, and psychotherapy is much more akin to the provider who is prescribing medications for cancer or high blood pressure than it is to the shaman who has an unreliable treatment technique to begin with. Therefore, I think that the provider has to assume responsibility then to create, if not belief in the power of his suggestion, at least compliance. The idea that, well, try it and see if it helps. Report back to me. Let's see if we can get an improvement. So I would favor compliance as a short-term goal in bringing about improvements in people who don't understand or who do not have a background of experience that would have convinced them when they come to see you that you're going to be able to help them.
Thank you. That's very helpful. So,
All right, anything else? Where do we stand?
No, that's all the question we have for today. Thank you so much, Dr. Ginsberg.
Thank you.
That will conclude our webinar for today.